Hi everybody, and welcome back to the channel. If you told me in 2019 that I'd be doing a YouTube video on long COVID, my reply would have been, what the hell is COVID and why is it long? Because clearly this disease has not been in existence for any more than 18 months. And of course long COVID didn't really start to appear until this time last year as a presenting symptom. But I'd like to pay tribute to Sesame Street to begin with, and this video is brought to you by the numbers 9 and 3.7 million. 9 because, whether you know it or not, you are presently living through the 9th deadliest pandemic in recorded human history. And 3.7 million because to date, 3.7 million people have succumbed to COVID-19. Which is a very, very sobering thought for a disease that didn't exist until 2019. Moreover, yesterday alone, about 525 people in the United Kingdom contracted COVID-19 and will go on to develop symptoms of long COVID. Worldwide, that figure is 47,000. 47,000 people in one day will have contracted COVID-19 and will probably go on to develop symptoms of long COVID. So this is going to be a very difficult problem to solve. It's going to affect many people in the future. It affects many people now. And of course this is not unprecedented because we've had ME and chronic fatigue syndrome, which we think in many cases are post-viral states. And in previous pandemics we've seen post-viral fatigue syndromes as well. So the 1918 Spanish flu pandemic was associated with a post-viral malaise or lethargy after that pandemic hit. And the Russian flu pandemic of the 1890s also seemed to be associated with post-viral fatigue syndromes. That pandemic killed about 1 million people, and there is a school of thought that that pandemic may have been caused itself by a coronavirus. But what I'd like to do in this video is take an exercise physiologist viewpoint of long COVID and the role that exercise physiology might play in long COVID diagnosis and management. I do have to point out though, a lot of what I'm going to be talking about is hypothetical because I have not been able to find an exercise test where we'd actually collect data from a long COVID patient that I could make sense of. So this is going to be a little bit difficult. We can start though with what long COVID is and what its prevalence is. And long COVID has been defined in a number of ways, but the most accepted way of looking at it is that post-acute COVID-19 is where symptoms persist beyond 3 weeks after the first symptoms present. Whereas chronic COVID-19 is where symptoms persist beyond 12 weeks. And Tricia Greenhall and colleagues have done a lot of work on this, but both of those are described as long COVID. Long COVID presents with an awful lot of different symptoms. So we have cough, breathlessness, fatigue, loss of smell, brain fog, cardiac arrhythmias, muscle pain and muscle weakness, and a great many others. It affects many different organ systems, and because it's a multi-system disease, these also affect all of those organ systems that are crucial to exercise tolerance. The precise prevalence of COVID-19, or rather long COVID, is not known, but at least 10% of COVID cases report lingering symptoms according to the two definitions above. What that means is long COVID could account for the experiences of more than 500,000 people in the UK already, and other estimates suggest that it's more than 1 million. And worldwide, at least 15 million people may be suffering from long COVID or have suffered from long COVID. And the problem is many of these individuals will be of working age, and so it's a potential societal time bomb in the future. When we take an exercise physiology perspective on this, most of the information about the loss of exercise capacity comes from 6-minute walk tests rather than cardiopulmonary exercise testing. And that's pretty obvious because most exercise physiology labs have been shut down for a year, and those that have reopened have a very, very low capacity and don't take on COVID-19 patients as part of the risk assessment. And so most of the functional capacity tests have been 6-minute walk tests. Now, the outcomes of those have been pretty stark. There's been very significant reductions in 6-minute walk test performance, but I would argue CPET testing is going to be important in the future to really home in on what long COVID is all about. And that's because of the different parameters that you can identify using CPET. Now, I've been through this before, so I won't labour the point, but you can detect and determine maximal oxygen uptake, the maximal power output, which is an index of exercise tolerance, provided, of course, that you maintain the same ramp rate between exercise tests. The gas exchange threshold can be measured, respiratory compensation point, the oxygen cost, so the relationship between work rate and the oxygen uptake, so the slope of the line that you can see with the red dots in the figure. The breathing reserve as a percentage of your maximal voluntary ventilation, especially if you've taken other respiratory or lung function test measurements before the exercise test itself. And the chronotropic scope, so the difference between heart rate max and heart rate rest, can also be determined, and the heart rate response to exercise as well. Now that can of course be fed into Wasserman's gears, and what we're essentially doing with a CPET test is spinning up the muscle gear in order to determine which of the muscle, heart or lung gears is dysfunctional. It might be one of them, it might be two of them, it might be all three of them. But the parameters and the responses that we measure in a CPET test can be used to detect which organ system is dysfunctional and in what way. And the way we do that is by using Wasserman's 9-panel CPET plot. And just to again go through these briefly, we have the gas exchange plot of VO2 and VCO2, the cardiovascular plot of the heart rate response and O2 pulse. We have the V-slope plot of VCO2 and VO2, ventilatory equivalence, minute ventilation against time, minute ventilation against VCO2, so we can detect the respiratory compensation point there. We have the end-tidal gases, which can also be supplemented with blood gases if you take invasive measurements. The respiratory exchange ratio plot, so we can look at the substrate utilization and also metabolic acidosis. And then we have the ventilatory plot, where we plot tidal volume against minute ventilation, so we look at the adequacy of the ventilatory response. So all of these can be used to determine exercise limitation and the organ system that might be causing that. Brings us on to long COVID pathophysiology, and of course the understanding of long COVID pathophysiology is evolving all the time because it's so new. But in terms of lung function, patients with long COVID may present with pulmonary fibrosis, especially those following severe acute COVID-19 infection. Those people who've been hospitalized may return with severely affected lung function as a consequence of pulmonary fibrosis. The presenting symptoms of that are cough and breathlessness and lack of exercise capacity. Now, breathlessness, of course, is not a specific symptom. You can also find that in response to muscle or cardiovascular effects as well. So you need to be careful about how you interpret that. In terms of cardiovascular function, we know that the lungs are affected by COVID-19 or by SARS-CoV-2 because of the ACE2 receptors in the lung. There are also ACE2 receptors in the myocardium, and so pericarditis, myocarditis, inflammation of the heart muscle is a possible effect of infection, as is vascular inflammation, and you've also probably heard of thrombosis and clots are occurring throughout this systemic circulation. Now, pericarditis and myocarditis are essentially infection of the heart muscle itself, can lead to arrhythmias, but could also lead to cardiac remodeling, and therefore symptoms that are not dissimilar to chronic heart failure. And then in terms of musculoskeletal function, of course the major presenting symptom there is fatigue, but you also have muscle pain, muscle weakness, and in the literature on long COVID, although it's very, very speculative, there is some discussion of potential mitochondrial dysfunction as a result of SARS-CoV-2 infection. Dennis in 2021 in BMJ Open presented this figure which shows the general presenting symptoms for those with long COVID as a function of the organ system that they were referred to in terms of the effects. There wasn't really any pattern in terms of different organ systems, but there were clear signs of fatigue in most patients, laboured breathing, muscle aches, headache, joint pain, chest pains, etc., etc. And then at the bottom there we have difficulty walking. Now that doesn't seem particularly significant, but if you've got 20 to 40% presenting with difficulty walking, then that suggests a very severe reduction in exercise capacity for those individuals who are probably able to run or certainly not have any difficulty walking before infection. So clearly there's something going on here that has a major impact on exercise capacity. So what I'd like to do is take a step-by-step approach to this, and what I've done is this is a CPET test that I performed on myself many years ago, and what I'm going to do is essentially alter this to make it look like I have long COVID associated with lung, cardiovascular and muscular pathology. Now I say again, this is entirely hypothetical because we don't have CPET data in long COVID, but it's just to point out the kind of effects that we might see. And so what we're going to focus on here for lung pathology is the gas exchange plot, the minute ventilation plot, and the ventilatory sufficiency plot, if you want to call it that. And so if you were suffering from pulmonary fibrosis or inflammation, you would essentially be presenting with a restrictive lung limitation. Under those circumstances, you would have tidal volume being curtailed by the attainment of your maximal inspiratory capacity, and your minute ventilation would be limited by the attainment of your maximal voluntary ventilation due to the lung damage. This would result in about a 50% reduction in maximal exercise ventilation, and this would directly result in about a 15% reduction in VO2 max, but no change in the gas exchange threshold. So that would be a key presenting pattern for pulmonary fibrosis. But you can see the significant reduction in exercise capacity there, even in somebody who's relatively healthy. If we think about cardiovascular pathology, now we're interested in the gas exchange response, the cardiovascular panel, and we're also interested in the ventilatory equivalence panel. So if we had a chronic heart failure-like reduction in exercise response and exercise tolerance, this is what we would expect to see. So we'd expect to see about a 30% reduction in the gas exchange threshold, so this presents very early in exercise. We would see a reduction in the O2 pulse, here modelled as a reduction of about 4 millilitres per beat. And what that would do to your gas exchange plot, well, first of all, you'd get a shallower slope in the VO2 versus work rate. So this is about it was 10 mils per minute per watt, it's now nearer 7. And that would result in an 18% reduction in VO2 max and about a 70 watt reduction in peak power output if you had the same ramp rate. So a substantial reduction in exercise capability following the cardiovascular aspect of long COVID. And then finally, muscular pathology or neuromuscular pathology. The reason this is interesting is because 98% of patients, according to Denny et al., they present with fatigue as a primary symptom. We've got to be careful about what we mean when we say fatigue, because this is an overarching fatigue and lethargy and malaise. These patients, however, also report muscle pain and muscle stiffness and exercise intolerance. Many of these patients report waves of fatigue episodes. They call it the corona coaster as a result. Fatigue itself could be cognitive in nature, so classical brain fog, or it could have a variety of central and or peripheral origins. And this Bigland-Ritchie figure points out from a neuromuscular perspective where fatigue might be operating from the higher brain centers and the motor cortex, through the spinal cord, the motor neuron, all the way through to the cross bridges. So any of these points could be a point of failure or could be a contributor to the fatigue process. Now, CPET might have a role to play in detecting some peripheral effects, particularly mitochondrial dysfunction, and I'll come on to that in just a moment. But as exercise physiologists, of course, we also have other tools in our armory, such as dynamometry, electrical stimulation, and electromyography, and that could be used to establish central and peripheral contributions to fatigue, as well as rule them out as well. Because if it's a general malaise and essentially an increase in perceived exertion in response to fixed bouts of exercise, that may come about without any change in peripheral or central physiological function. So we really ought not to rule anything out at this stage. But what if it's a muscular pathology? Well, now we're going to look at a number of different panels. So again, we're going to look at the gas exchange panel, we're going to look at the ventilator equivalent panel, we're also going to look at VE and RER in this case, because we want to know if there's any metabolic changes. So what we'd expect to see if there was some kind of derangement in mitochondrial respiratory chain function is this. We'd expect to see very exaggerated VE-VO2 responses and VE-VCO2 responses, but also a very, very low gas exchange threshold. In fact, so low you might even miss it. You'd expect very exaggerated respiratory exchange ratio responses as a result of an inability to consume oxygen. You'd have to be much more reliant on anaerobic metabolism, and therefore you get very exaggerated minute ventilation and heart rate responses. This would result in a 30% or more drop in VO2 max, a very low gas exchange threshold, and the exaggerations that I've previously mentioned. So very severe depletion in exercise tolerance under these conditions. Does this fit with long COVID? Well, right now we simply don't know. But let me give you an example of somebody who is really suffering from mitochondrial respiratory chain deficiency. So here we have data from Haller et al. In 1989 in the Journal of Clinical Investigation. And what you have is a bunch of control subjects and a patient with a mitochondrial dysfunction. And what you see in the patients or the patient and the control group at rest, there's very little difference between them at rest. It's only during exercise, and this is maximal exercise, where you see differences. Maximal work rate in the control group, about 136 watts. In the patient, 21 watts. The VO2 response, so maximal VO2, 32 in the patient, in the control group, only 11 in the patient. There's an extremely exaggerated VE-VO2 response and VE-VCO2. And look at the RER, so the maximal RER for the control group, 1.16, for the patient, 1.7. But the biggest difference you can see here is in the systemic AVO2 difference. Normal in the control group, extremely low in the patient. This patient is having real difficulty extracting and utilizing oxygen because of their mitochondrial deficiency. And this individual, throughout their life, because it was a genetic condition that they were suffering from, they were unable to do anything much more than a slow walk before they started suffering symptoms of essentially being in the severe intensity domain, very, very difficult exercise conditions. Now, how might this relate to long COVID or other post-viral fatigue states? We don't know for long COVID, but maybe chronic fatigue syndrome and ME is a window into long COVID. And these are data from Inbar et al. In 2001, Med-Sci Sports Exercise, working alongside Brian Whip. And you can see in these patient groups that there is a significant reduction in VO2 max, so 20 versus 27 in milliliters per kilogram per minute, and also, crucially, a significant reduction in the gas exchange threshold, so 19 versus 13.5. Now you might say, well, VO2 max is an effort-dependent measure, so maybe these patients were not reaching a true maximal effort. And that may be true, but that can't explain why the gas exchange threshold is so much lower. And you might turn around and say, well, maybe the gas exchange threshold is that much lower because they're deconditioned, because they've got chronic fatigue syndrome. Well, that's possible, but then here are some data from Snell et al. From physical therapy, and what they showed was that the effect of CFS, if you do a ramp test or a CPET test on day 1 and then follow it up with a CPET test on day 2, what you're seeing here is a post-exertional exacerbation. So in their group, they didn't see any difference between, or only a small difference in gas exchange threshold between the control group and the patient group on day 1. But on day 2, there was a significant reduction in the chronic fatigue syndrome group, but not in the control group. In other words, this exacerbation reduced the gas exchange threshold. And you really can't explain that by there being a deconditioning effect. This is an acute effect of an exacerbation. And so that probably throws the effect on the gas exchange threshold, or in this case the ventilatory threshold as they call it. There's probably some direct relationship between the fatigue state that they're suffering and some peripheral effect that's affecting the gas exchange threshold. We don't know what that is at the moment. Now, many of you are interested in athletes and how you might manage long COVID in those athletic populations. Well, there is a consensus statement on this from Stanford Hall just north of Loughborough, the Defence Rehabilitation Centre, and they've made a consensus statement that you can find in the British Journal of Sports Medicine. I'll put a link to that in the description. One of the things they recommended in that consensus statement is you should avoid using the neck test with any COVID-19 symptoms. Now, the neck test, for those of you who are not aware of it, is this idea that if you have a virus or a cold or the flu, if you have the symptoms in your nasal passages, so runny nose, sore throat, that kind of thing, well, at that point you can carry on training if you feel well enough to do so. Whereas if these symptoms appear below the neck, in other words, you've got a chesty cough, then you should avoid training. Well, the guys at Stanford Hall could find no empirical evidence whatsoever to support the use of the neck test in deciding whether to train or not. And they argued that because these things are systemic, if you've got any kind of viral infection, you should avoid training. They also suggested to rest before returning to training, and they suggested that period should be 3 to 4 weeks, rather than the usual recommended 7 to 10 days after symptoms have abated. And that's to try and avoid the development of long COVID symptoms. And the return to training should be very gradual. And so they've recommended considering strengthening exercises before reintroducing cardiovascular work, again because of the nature of COVID-19. It has to be said, though, the statement was written in April 2020, and so long COVID wasn't fully established at that point, although there was some indication that it might be happening. One of the key things to come out of all of this is that CPET may be critical in the diagnosis of different symptom clusters and trying to understand what aspect of long COVID a particular individual is suffering from. But of course, all of this is rather hypothetical because there aren't any data on this at the moment. And so some final thoughts from me on this. Well, first of all, long COVID is likely to remain an issue for years to come. And even if it isn't, ME and chronic fatigue syndrome always have been an issue and always will be. And I think one of the things that perhaps one of the only positive things to come out of the pandemic is that ME and CFS patients may actually be taken more seriously because of the prevalence of long COVID and the similarity in the way in which long COVID seems to progress. And as exercise physiologists, we need a better understanding of post-viral fatigue and the role that exercise can play in both the diagnosis and the management of post-viral fatigue states. And so thank you very much for listening to my ramblings. They were kind of ramblings because this is obviously a lot of this stuff is so hypothetical that I was having to ramble. But thank you very much for listening to it. And if you enjoyed it, please like and subscribe to my channel. And I hope to see you next time. Thank you very much.